Vignette number 15, a 61-year-old man presents with a history of hematuria. Intravenous pyelogram shows a renal mass. Sonogram shows it to be solid rather than cystic. CT scan shows a heterogenic solid tumor. This is another excellent description of a renal cell carcinoma. In fact, in this vignette, what I did was include for you what is the sonographic picture of a renal cell carcinoma, what is the CT picture of a renal cell carcinoma. Now let's move on, vignette 16. A 55-year-old chronic smoker reports 3 instances in the past 2 weeks when he has had painless, gross, total hematuria. In the past 2 months, he's been treated twice for irritative voiding symptoms, but has not been febrile, and urinary cultures have been negative. Well, it's hematuria, so you're going to work it up anyway. But if you were asked on a multiple, extended matching set, what do you think this is? The answer is actually bladder cancer. Every person in the U.S., not only every physician, every person in the U.S. knows that there is a relationship between smoking and cancer of the lung. But what many people do not know, and in fact some physicians may not even know, is that there is an even tighter association between smoking and cancer of the bladder. So this is a chronic smoker. He has irritative bladder symptoms. He has hematuria. This is bladder cancer. Now you might be tempted to say then, well, if that's what I'm thinking, the first diagnostic study should be the cystoscopy. My friends in urology tell me, no, you should always begin with the IVP and then do the cystoscopy. And I've asked him why. If I think the money is in the bladder, why don't I look at the bladder to begin with? And the reason they give me is that the same transitional epithelium that covers the bladder covers the ureters and the renal pelvis. And you might have more than one tumor. You might have one in the bladder and one in the ureter. If you begin with the cystoscopy, you see the tumor in the bladder. You may zero in, do the treatment, and never see the other one that the IVP would have shown you. So I have been told by my friends in the field, it should be IVP first, cystoscopy later. Let's do it that way. All right. In all of these vignettes that we have talked about the workup of hematuria, let me remind you one more time that if there is a contraindication to the IVP, obvious in the vignette, and that would be poor renal function, that then your choice is a CT scan rather than an IVP, and then the cystoscopy. All right, let's move on now to cancer of the prostate. There are 2 ways that cancer of the prostate can show up before it is clearly symptomatic. It's either a rock-hard, discrete nodule that can be felt on rectal exam, or it is an elevated level in the PSA, the prostatic specific antigen. And these are the next 2 vignettes. A 59-year-old black man has a rock-hard, discrete 1.5 cm nodule felt in his prostate during a routine physical examination. Or vignette number 18, a 59-year-old black man is told by his primary care physician that his prostatic specific antigen, PSA, has gone up significantly since his last visit. He has no palpable abnormalities in his prostate by rectal exam. Why did I make both of these black patients rather than white? Because they have a higher incidence of prostatic cancer and they get it at an earlier age. So I would not be surprised if you have a question on the exam meant to be prostatic cancer, the patient portrayed for you on the question will be a black male. So in both of these, we need to proceed then to biopsy what we think is a prostatic cancer. The first one is easy. It was felt by rectal exam. Well, that same finger then can guide a transrectal needle biopsy of the mass. But what about the second one? It was found by the PSA. It was not palpable to begin with. Well, in that case, then a sonogram, a transrectal sonogram of the prostate, should identify the area and enable us then to do the biopsy. Once you've done the needle biopsy of the suspicious area, the next step in management, there is a bewildering number of choices. Because prostatic cancer in its early stages can be treated with radiation, it can be treated with radioactive seeds that are implanted directly, can be treated with surgery, so there are a number of ways. Again, it's difficult to make a simple, easy decision, and I don't think in the USMLE they will force you to make such a choice. Vignette number 19. A 62-year-old man had a radical prostatectomy for cancer of the prostate 3 years ago. He now presents with widespread bony pain. Bone scans show metastases throughout the entire skeleton, including several that are very large and very impressive. In advanced prostatic cancer, if it hasn't already been done, dramatic palliation can be obtained by eliminating the androgens from the patient's body. This can be most effectively and economically done with an orchiectomy. It will not provide long-lasting relief, but typically a couple of years. 2 years of good palliation are achieved with orchiectomy. If a patient doesn't want to have an orchiectomy, an expensive alternative is luteinizing hormone-releasing hormone agonists or anti-androgens like flutamide. Far more expensive and, of course, not a permanent thing, because the minute you stop taking the medicine, you don't have the benefit anymore. All right, vignette number 20. When I wrote that vignette and I showed it to my colleagues in urology, they said, your imagination is running wild. That would never happen in real life. That's not a good vignette. But I left it here to illustrate an important point, and I'm going to read only part of the vignette to make that point. An 82-year-old man who has congestive heart failure and chronic obstructive pulmonary disease is told by his primary care physician that his level of prostatic-specific antigen, PSA, is abnormally high. Let me stop there. That shouldn't have happened. We do, as part of good preventive medicine, rectal exams and PSAs in asymptomatic men, so we can detect their cancer of prostate when it's an early stage and we can cure them. But there's an age limit to doing that. Every male, unless he's been castrated, every male, if he lives long enough, will eventually develop prostatic cancer. And yet that's not the same as saying that every male will die of prostatic cancer. Men who develop prostatic cancer late, very late in life, are going to die of something else, not from the prostatic cancer. And neither mortality, nor longevity, nor quality of life will be affected by the fact that they have a very early cancer when they are old enough they're going to die of something else. And so, as depicted on this vignette, an 82-year-old man with congestive heart failure and chronic obstructive pulmonary disease should never have had the PSA in the first place. And that's the point that I make. In fact, the age limit usually quoted is 75. Now, you might get this question perhaps in a better way by saying, you have joined the health maintenance organization, and one of your patients is 75 years old, and he asked you during your routine physical exam, doctor, shouldn't I get the PSA? And then you pick the answer that says you explain to the patient that beyond that age it's not useful to do the PSA anymore. All right, let's move now to testicular cancer. Vignette number 21, a 25-year-old man presents with a painless, hard testicular mass, and if you have this vignette in an extended matching set, the answer is this is testicular cancer. Testicular cancer is one of those cancers that belongs to young people. It happens to young males, not to old males. And testicular cancer presents just as this vignette describes, a painless, hard testicular mass. Now, if you don't know what the correct answer is, You're going to be horrified. Because the correct answer for this vignette is we do a radical orchiectomy by the inguinal route, and after we did the radical orchiectomy by the inguinal route, we asked the pathologist, hey, was that a cancer that I took out? And you say, how could you possibly do this horrible mutilating operation before you had a diagnosis? But it so happens that in young men, if there is a hard testicular mass and you are sure clinically it's arising from the testicle, not from other structures in the scrotum, they are all cancers. Young men do not get benign testicular cancers. They don't exist. And so a hard testicular mass in a young male is a cancer and needs to be addressed with a radical orchiectomy of the inguinal route. Again, the only diagnostic dilemma here might be if you're not sure that it is arising from the testicle. If you're giving a vignette that says there is a mass in the scrotum, but some examiners feel that it comes from the epididymis, and another person says, I think it comes from the testicle, you wouldn't do an orchiectomy for that. In fact, you would start with a sonogram, see where the mass is coming from. But if it's clear in the vignette, this is not epididymis, this is a testicular mass in a young man, the answer is a radical orchiectomy, and it has to be by the inguinal route. Every other answer on that question that uses the transscrotal approach is wrong. Transscrotal needle biopsy, transscrotal incisional biopsy, transscrotal orchiectomy, all those are wrong. If you go through the scrotum, you spread the cancer. Let me add that as we're getting ready to do this radical orchiectomy by the inguinal route, we also take blood samples to measure the serum markers that are typical for many testicular cancers. The alpha fetoprotein, the beta HCG, because they are going to be very useful for follow-up later on. Not that they are going to change the need to do the radical orchiectomy by the inguinal route. All right, vignette number 22. A 25-year-old man is found on a pre-employment chest X-ray to have what appears to be pulmonary metastasis from an unknown primary tumor. Subsequent physical examination discloses a hard testicular mass, and the patient indicates that for the past 6 months he's been losing weight for no obvious reasons. And you might say, oh my God, this is incurable. This young man has a testicular cancer, he's already metastatic to the lung. So let me look for an answer here that says palliative care. No, don't look for that. Most testicular cancer, there are exceptions, but most testicular cancer are exquisitely radiosensitive and chemosensitive, particularly to platinum-based chemotherapy. We don't give up on extensive testicular cancers, we treat them. So this young man needs a radical orchiectomy of the inguinal route, so we know exactly what kind of tumor it is that he has, and so we remove the primary tumor. And then we put him on the systemic chemotherapy, platinum-based, and we wouldn't be one bit surprised if that metastatic growth in the lung disappears. We, in fact, would not be surprised if he were cured. It can happen. You can cure testicular cancer even when it is widespread. Let's talk about retention and incontinence next. Vignette number 23, a 60-year-old man shows up in the ER because he has not been able to void for the past 12 hours. He wants to, but cannot. On physical exam, his bladder is palpable halfway up between the pubis and the umbilicus, and he has a big, boggy prostate gland without nodules. He gives a history that for several years now he's been getting up 4 or 5 times a night to urinate. Because of a cold, 2 days ago he began taking antihistaminics, using nasal drops, and drinking plenty of fluids. This is a classic. This is seen in our emergency room several times every weekend. This is a gentleman that has acute urinary retention with underlying benign prostatic hypertrophy. I mean, the history is there. 60 years old, he's been getting up to void many times at night. He has BPH, has benign prostatic hypertrophy. But because of the cold, he takes antihistaminics and uses nasal drops. Those nasal drops often have alpha adrenergic substance. That's how you get the vasoconstriction in your nose. But you absorb some of that alpha. And if you remember, it is alpha fibers at the bladder neck that close the bladder neck. That's why patients with benign prostatic hypertrophy are given alpha blockers as medication so they can urinate easy. So very commonly, this individual who already had difficulty emptying the bladder precipitates the acute retention by the use of the antihistaminics and the nasal drops. And of course, the problem is compounded by the fact that he's drinking plenty of fluids. And now that plenty of fluid has no place to go. This man needs an indwelling bladder catheter. In and out catheterization will not do it here because it will be right back here. This bladder neck is tightly contracted. This bladder is very distended. So indwelling Foley catheter is going to have to be left in there for at least 3 days. And then long-term therapy, we nowadays have a lot of options. At one time, the only thing that could be offered was TURP, transurethral resection of the prostate. That can still be offered today. But now we have medical means, alpha blockers, I mentioned, are commonly used. And if we go for mechanical solutions to the problem, we have a number of choices there as well. Okay, vignette number 24, on the second post-operative day after surgery for repair of bilateral inguinal hernias, the patient reports that he cannot hold his urine. Further questioning reveals that every few minutes he urinates a few cc's of urine. On physical examination, there is a large palpable mass arising from the pelvis and reaching almost to the umbilicus. This is acute urinary retention with overflowing continence. Now, this shouldn't have happened. In every well-staffed and well-run hospital, a post-operative patient having hernia repairs, if he doesn't have a bladder catheter in place already, there is an order that says if a patient hasn't voided in 6 hours, notify the physician so that this is prevented. But if for some reason it wasn't recognized that the patient was not urinating, and the bladder is allowed to fill to this enormous extent, eventually the hydrostatic pressure within the bladder overcomes the pressure of the sphincter, and a few cc's of urine come out over which the patient has no control. That's why the patient is reporting, I cannot hold my urine, because during the evacuation of those few cc's, he cannot control that. It's just coming out. But as soon as that pressure goes down a little bit that way, the bladder neck wins again, and you get retention again, and this keeps happening. So this man obviously needs an indwelling bladder catheter. The diagnosis, though, for the vignette is acute urinary retention with overflow incontinence. And let's talk about another kind of incontinence that is very common. A 42-year-old woman consults you for urinary incontinence. She is the mother of 5 children. I should add here vaginal deliveries, all 5 of them. And ever since the birth of the last one, 7 years ago, she leaks a small amount of urine whenever she sneezes, laughs, gets out of a chair, or lifts any heavy objects. She relates that she can hold her urine all through the night without any leaking whatsoever. Classical picture for stress incontinence. We see it in this kind of patient. The patient that has had the multiple repeated trauma to the perineum from vaginal deliveries. Here's what happens. A normal female anatomy, as we've indicated before, doesn't really provide a long urethra with a long sphincter like the male has. There's a very short urethra with a short sphincter. But in the normal anatomical position, that sphincteric area of the urethra as well as the rest of the bladder are all above the perineal floor. When increased intra-abdominal pressure squeezes on the bladder and makes the bladder want to empty, that same increased pressure is applied to the sphincter, and so the balance remains favorable and the patient doesn't want. But if, because of the multiple deliveries, we have lost now the pelvic floor, and now the lady has a cystocele, and now the urethra and the sphincter are outside of a high-pressure intra-abdominal area. Now when she sneezes and laughs or tries to, lift her grandson, with a pressure on the abdomen not matched by similar pressure where the bladder neck is, the body of the bladder gets the intra-abdominal pressure, the bladder neck does not, the lady leaks. This is a stress incontinence. And a surgical repair of the pelvic floor will take care of it. All right, let's move to the subject of stones. A 72-year-old who in previous years has passed a total of 3 urinary stones is now again having symptoms of urethral colic. He has relatively mild pain that began 6 hours ago and does not have much in the way of nausea and vomiting. X-rays show a 3-millimeter urethral stone just proximal to the uretero-vesical junction. Urologists have at their disposal a bewildering array of high technological gadgets. In fact, it's one of the things that they always say is one of the attractive things about their specialty. They can play with all these toys. And in the case of urinary stones, they have ways to shatter them with sound waves. They can crush them with baskets. They can pulverize them with lasers, all kinds of nifty gadgetry. But just because we have all that gadgetry doesn't mean we have to use it every time. This gentleman, as described in this vignette, is probably going to pass that stone given enough time. It's a small stone, 3 millimeters. It's already waiting to get into the bladder. It already negotiated all the urethra. It is at the uretero-vesical junction. And so the appropriate management here, still being done every day in spite of availability of the gadgetry, is plenty of fluid, some medication for pain, and let's wait until the man passes the stone, which he will probably do. Let's contrast that to the next. In year 27, a 54-year-old woman has a severe urethral colic. IVP shows a 7-millimeter urethral stone at the uretero-pelvic junction. This is a big stone, 7 millimeters. This is way up, has not negotiated the urethra. This one doesn't really have a good chance of doing so. In fact, the previous vignette, the 3-millimeter stone way down next to the bladder, has about a 70% chance of passing. A 7-millimeter stone that hasn't negotiated the bladder, 5% at best, the likelihood that it would go out by itself. This one needs help. Well, of all the gadgetry that is used, probably the one most commonly used, certainly the one for this one, is extracorporeal shock wave lithotripsy. This is that procedure where the patient is put on a water valve in which shock waves are applied, which disintegrate the stone. As long as we're talking about using the shock wave lithotripsy, let me remind you of the contraindications. We cannot use it during pregnancy. The baby obviously would not appreciate all that sound. We cannot use it if there is a bleeding diathesis, and we cannot use it if the stones are very big. One of those big Staghorn calculi that are several cms in diameter. If we shatter that with a shock wave, we can shatter it, but then we're going to have dozens or maybe hundreds of stones of 5 or 6 or 7 millimeters each that are going to be bigger problem than what we had to begin with. So When they are huge, we're better off removing them surgically. All right, let's talk about a few miscellaneous things. A 72-year-old man consults you with a history that for the past several days he has noticed that bubbles of air come out along with the urine when he urinates. He also gives symptoms suggestive of mild cystitis. No, the gentleman doesn't have an overactive imagination. He's not pulling your leg. Yes, this happens, and this is the classical presentation for a fistula between the GI tract and the bladder, which most commonly happens between the sigmoid colon and the bladder, and is in turn most commonly due to diverticulitis. So this is why the gentleman has pneumaturia, air with the urine. Well, now, if you say, well, this is a hole between the bladder and the sigmoid, I know how to make the diagnosis. I can put radiopaque dye in the bladder and watch it go into the sigmoid. I can put barium into the sigmoid, see it go into the bladder. I could do an endoscopy of the bladder, see a big hole, and look at the sigmoid, or I could do an endoscopy through the sigmoid, see a big hole, and look at the bladder. None of which are the correct answer. If you had a hole that big, the urosepsis would be so gigantic the patient would be dead. When we first see these things coming, with a pneumaturia, the mild signs of urinary tract infection, what we have is a pinhole, teeny bitty opening, big enough for the air to go through, big enough for the bacteria to go through, but not big enough to look at it. In fact, if you do a cystoscopy, all you see is a little redness in the area in the center of which is a little hole that actually you cannot see. So the way to diagnose this is a CT scan. We do a CT scan, and the CT scan will show the inflammatory mass of the diverticulitis, which in turn led to the fistula. After we do that, we better do the proctosigmoidoscopic exam also, because even though I mentioned these are most commonly due to diverticulitis, the second possible genesis of them is a cancer of the sigmoid that has eaten its way into the bladder. The third and very distant possibility would be a cancer of the bladder eating its way into the sigmoid. But because the second possibility is a cancer of the sigmoid, we have to be sure that we rule that out as well. Eventually then surgery will be done to disconnect these two things, to remove the sigmoid that has either a tumor in it or diverticulitis in it, and to close the dome of the bladder. When I have a couple of vignettes that have to do with impotence, what today is called erectile dysfunction. Let me go into a little background first. There are two kinds of impotence: psychogenic impotence and organic impotence. The psychogenic impotence invariably has sudden onset because it is related to some event that was psychologically traumatic to the patient. Sudden onset. But it's also very specific to a particular circumstance. The patient cannot have erections and intercourse, but it still gets nocturnal erections, still is able to masturbate. In fact, sometimes it is selective to a particular partner. Organic impotence, on the other hand, if it is due to trauma, will also have sudden onset, but of course timely related to the trauma. But the more common organic impotence due to arteriosclerotic occlusive disease, due to diabetes, has very gradual onset. At first the patient still gets erections, but they don't last as long as they used to. Later on, the erections don't have the quality they used to have, may not be sufficiently, rigid for penetration to occur. Eventually, there are no erections at all. And this, loss of function is universal. It doesn't happen just with one partner and not with another. In fact, at the end of the, progression, when there are no erections at all, there are no nocturnal erections either. There are no erections with attempted masturbation. Okay, let's read out a few vignettes. Year number 29, a 32-year-old man has sudden onset of impotence. 1 month ago, he was unexpectedly unable to perform with his wife after an evening of heavy eating and heavier drinking. Ever since then, he has not been able to achieve an erection when attempting to have intercourse with his wife, but he still gets nocturnal erections and can masturbate normally. Classical example of psychogenic impotence. Sudden onset, very specific to a particular set of circumstances. This man can be cured with psychotherapy provided it's done promptly. If this is neglected, if several months go by, this becomes a permanent block for this individual. So the correct answer on this one is not only the one that says psychotherapy, it's the one that says psychotherapy as quickly as possible. Avenue number 30, ever since he had a motorcycle accident where he crushed his perineum, a young man has been impotent. Avenue number 31, ever since he had an abdominal perineal resection for cancer of the rectum, a 52-year-old man has been impotent. Now here we have two examples of organic impotence, but due to a traumatic event. They happen immediately after a traumatic event. But there's a difference between the two. The young man who had the motorcycle accident and crushed his perineum and since then has been impotent, he's got a vascular injury. And he therefore is amenable to a vascular repair. The gentleman, on the other hand, who had the abdominal perineal resection for the cancer of the rectum, what was injured in his case is the plexus of erectile nerves that are very close to the rectum and sometimes cannot be spared during the course of abdominal perineal resection. We cannot reconstruct those. So the only help that is available to the second of these two gentlemen is prosthetic devices. Either the vacuum device that achieves erection in that fashion, or the implants that are permanent devices. Avenue number 32, a 66-year-old diabetic man with generalized arteriosclerotic occlusive disease notices gradual loss of erectile function. At first he could get erections, but they did not last long enough. Later the quality of erection was poor. Eventually he developed complete impotence. He does not get nocturnal erections. This is organic impotence. And this is the one that in fact responds best to Viagra. Recently introduced pharmacological agent that is extremely helpful in situations like these, because as you know it breaks down the enzymes that normally would have terminated the vasodilation on which erection depends. So by the use of Viagra, this situation can be corrected. Well, we're approaching the end of our review. We have a few vignettes left. They have to do with transplantation. Vignette number 1 is a 62-year-old man who had the motorcycle accident, has been in coma for several weeks. He's on a respirator, has had pneumonia on and off, has been on vasopressors, and shows no signs of neurological improvement. The family inquires about brain death and possible organ donation. You know, at one time we were very fussy about who did we accept as a donor for organs to be transplanted. They had to be young, they had to be healthy, they could not have been on antibiotics or on vasopressors or on respirators. I mean, you virtually had to be a perfect specimen except you were dead, brain dead that is. Nowadays, the biggest problem in transplantation is the enormous disparity between the number of patients awaiting to get a transplant and the very limited number of donors available. All of those criteria have been liberalized to a tremendous degree. And virtually everyone today is a potential donor. I shouldn't say everyone. There are still some patients that cannot be used as a donor. But now physicians are being asked never to make that judgment themselves. Physicians are being asked, every potential donor, please refer to the harvesting teams, and let the harvesting team reject the very few that cannot be used. And it's in fact amazing the degree to which we now use donors. Age is no longer a barrier. Even things that at one time were absolute prohibitions. Let's say a donor with hepatitis. Well, now we use them. We give those organs to recipients who have hepatitis. So there isn't a transmission of a disease there. We can even use the cornea of patients with cancer. Cancer having been always one of the reasons to reject a potential donor. So if you have a question on the exam that says, can we entertain the possibility of this individual as an organ donor, the answer is yes. All right. The next few vignettes have to do with rejection of solid organs that have been transplanted. Let's go into the background before we read the vignettes. There are three kinds of solid organ rejection. There is a hyperacute rejection that happens within minutes of reestablishing vascular supply, which is due to preformed antibodies and which is irreversible. It destroys the graft immediately. We don't see that one clinically anymore because we have learned to prevent them. So every transplant that is done today is compatible on the ABO blood groups, and a suitable test has been done to rule out the presence of preformed antibodies. The second kind of rejection is the acute rejection. This is the common one. The acute rejection is the one that happens predictably to every transplanted organ, sometime between the first 2 or 3 days to as late as within the first month or two of the transplant, even while the patient is on immunosuppression. That is the one that we can diagnose, and that's the one that we can reverse, typically with a bolus of steroids or, if needed, with anti-lymphocytic agents. And there's a third form of rejection, poorly understood, the chronic rejection. That one shows up years after the graft was placed as an insidious, gradual loss of graft function, and we have no way of reversing it. We have no treatment for it, and the only thing we can do is put another transplant on that same patient. Now then, the common rejection then we're going to see on the exam is going to be the acute one. How does that show up? With one or two exceptions that I'm going to mention in a minute. It shows up with decreased function of a transplanted organ. So the question will give you the history that a patient had a transplant, was put on immunosuppression, and within, from a few days to perhaps a month or two, there is an episode when there is decreased function of the graft, and then we do biopsies of the graft. This verifies that yes, the problem is acute rejection, and then we do the steroid boluses, or if needed, the anti-lymphocytic agents. But there are two exceptions. First exception is the liver. Liver transplants are technologically the most challenging of them all. The liver transplant takes 20-some hours to do. And it involves many vascular anastomoses. We have to anastomose the portal vein, the hepatic artery, the hepatic veins, and biliary anastomosis. And to our very happy surprise when we began doing this, it turns out the liver is not a terribly antigenic organ. It's better tolerated than other organs that we might transplant onto somebody. And the bottom line then is when we see in a patient with a liver transplant decreased liver function, impairment of the liver function, the first diagnostic things are not a rejection episode, but mechanical problems with either the vascular or the biliary anastomosis. And only when those have been ruled out do we then consider, well, it must therefore be rejection, and then we do the biopsy of the liver. And I have an example. The second exception where we don't see the deterioration in the organ is a heart transplant. It so happens in a heart transplant that once deterioration of function is evident, it's too late to salvage the graft. And so in heart transplants, we don't wait to see deteriorating function. We do biopsies on an ongoing basis. There is a schedule of how often we do biopsies after a heart transplant. We do them percutaneously via the superior vena cava down through the right atrium into the right ventricle, vital piece of the ventricle. And this is how we do the control of the rejection episode. Let me read the vignettes. Vignette number 2. 10 days after liver transplantation, levels of GGT, alkaline phosphatase, and bilirubin begin to go up. If this is all you were given on the vignette, and you were asked, what are you going to do next? You do ultrasound for the biliary anastomosis. You do Doppler studies of the vascular anastomosis. That's where you think the problem is going to be. Well, in this case, it was already done. There is no ultrasound evidence of biliary obstruction or Doppler evidence of vascular thrombosis. Then we do percutaneous biopsy of that liver, because this is probably then a rejection episode, and we need to use the steroid boluses or the anti-lymphocytic agents. Vignette number 3, on the 3rd week after the closely matched renal transplant, there are early clinical and laboratory signs of decreased renal function. There, the thing to do is the biopsy of that renal graft. It should show an episode of acute rejection, and we use the steroid boluses. Vignette number 4, 2 weeks after a long transplant, the patient develops fever, dyspnea, hypoxemia, decreased FEV1, an interstitial infiltrate on chest X-ray. Again, the most likely thing that's happening is the rejection episode. We do endobronchial biopsies and treat the rejection episode. And finally, the last vignette. Several years after a successful, and this could be renal, hepatic, cardiac, pulmonary transplantation, there is gradual insidious loss of organ function. When it happens several years down the line, it probably is that poorly understood, irreversible chronic rejection. But because there is the outside chance that maybe we're lucky, and this is a very late episode of acute rejection, the answer on the exam for this, it's let's biopsy the organ. If that biopsy proves that it is chronic rejection, then all we can do is begin to look for another donor, because that graft is going to have to be replaced. But if by chance it is acute, then we can reverse that. Well, that concludes the review, and I wish you the best of luck in your USMLE exam.